demonstration days, they're never possible without the support of our industry support. So we've decided to give, not only with them having the 10 minutes, but because we've now gone Zoom, all of our presence, all of our support is going to give us a little presentation of the industry challenges and what's new. So I'm going to hand over first to Clicksmart, to Dr. Michael Sinnott, who is a co-founder of Clicksmart for us.
I would like to thank Joy, Elaine and Ruth for giving me the time to speak with you this morning. What I've witnessed so far is people tackling two impossible tasks: fixing access block and understanding a budget with so many variables. So I'd like to give you a brief story on another impossible task, which is commercialising a medical device from Brisbane. So let me start with the Clicksmart story by introducing two remarkable people, both great friends and colleagues. The first is Dr. Neville Henry in the top left photograph. Neville has invented all our award-winning scalpel blade removers. He has also invented a large range of other practical solutions when he was working in various countries for the International Red Cross. In fact, Neville was awarded an AM for his volunteer work. Despite his brilliance, Neville is a very quiet and modest man, and as a result is often underestimated. Even I had to learn about some of his achievements secondhand. For example, he worked in PNG after he finished his residency, and he was awarded a scholarship to do a Masters in Public Health at Harvard. One of his International Red Cross duties was to go to Rwanda for 3 months. When he was there was a riot in a neighbouring refugee camp, and over 600 people were injured. Neville, a nurse and an old taxi converted into an ambulance, managed part of this casualty by themselves. Now let me introduce Anne Codkill, RN. Anne was an old-fashioned salt-of-the-earth nurse, her words. Very smart, very practical, and very much in charge of the GP end of our ED. Anne set a very high clinical standard, but always maintained her sense of humour. Anne was Neville's biggest fan, and she is. Neville did all the minor procedures in the ED, and Anne used to remove the scalpel blades at the end of the procedures with the parabellum artery forceps tied by a bit of endotracheal twill to a sharp spin. And one day in frustration, it was a Friday, she said, there has to be a better way. That weekend, Neville literally went into his garage under his house and invented what's now known as the Clicksmart blade class, which was the world's first single-handed scalpel blade remover. The first prototype was housed in an old cyclosporin jar. Neville and I got together and we thought the best way to bring this device into clinical practice, where it has to be to improve safety, was to sell it off on a royalty basis. So Neville was probably in Rwanda or somewhere else. I went to Becton Dickinson in the States, but the person I had an appointment to meet with to show our device was on holidays. I then went to Swan Morton in Sheffield in the UK, and they reviewed it and said it was the best scalpel blade remover they'd ever seen because it worked first time, every time. However, they said they didn't have the resources to commercialise it that year, which I thought was a polite way of saying go away. However, over the last 20 years I've learned exactly what they meant by that. We came back and established a company back in 1994. We managed to get a government grant, and after 2 years of intensive work, we had a tool-ready product. Little did we know that that was the easy bit. Early on, I was given advice that took me years to understand. I was told that bringing a brand new idea with no competitors to market was much, much harder than bringing a device to market that was just better than the one in an already established market. So we had the world's best scalpel blade remover by a country mile, and the HIV/AIDS pandemic had highlighted the importance of staff safety probably for the first time, and it had highlighted the importance of avoiding shafts injury, but that wasn't enough. Changing the practice of clinical staff is only second in difficulty to changing the practice of surgeons. We would like to think that we were one of the first early champions of the importance of staff safety. We have done this through decades of research, publications, conference presentations and advocacy. We worked with accreditation bodies like the Joint Commission in the States and the ACHS in Australia to increase their focus on staff safety and not leave it completely focused on patient safety. To make this easier, we developed the Staff Safety Scorecard that uses purchase data as a surrogate marker of compliance with safety policies and legislations. Some of our advocacy work is highlighted in the top left photograph. So that's myself presenting to the Michigan House of Representatives Healthcare Committee. I thought it was going to be a friendly chat, but it turned out to be extremely formal. They went on to pass a resolution saying that the Joint Commission should include the Staff Safety Scorecard in their audits. We repeated this for the Sinnott in Michigan, and they also passed a resolution. Unfortunately, when it came to trying to get legislation, the Private Hospital Association stopped it because they didn't want to commit budget to staff safety. We would like to think that we were one of the first in the world to promote the link between staff safety and patient safety. We've done this through the same methods. In the slide on the right, partly covered up, is the Minister of Health from Malaysia. So last year, the World Health Organization hosted the first global patient safety day in 194 countries. Based on the research we've done, I was invited to give a keynote address in Malaysia. Unlike the other speakers, I spoke about the relationship between staff safety and patient safety. Queensland Health has recognised that sharps injuries are a significant issue for all healthcare workers, especially within the perioperative environment. We published earlier this year a study from the PA that showed that for every 100,000 scalpels you buy, there will be 12.6 injuries, and that was averaged over 3 years. Not surprising to you, the number of injuries from suture needles is 39. What surprises a lot of people is the number of injuries from blood-borne needles is a lot lower, per 100,000, only 2.65. Janine Jager in the States studied and published a paper looking at how safety had changed from when Bill Clinton passed the Needle Stick Safety and Prevention Act. So 10 years later, they found that sharps injuries across the hospital had dropped by 31%, but in the operating theatre, they'd gone up by 6.5%. And the two leading causes were suture needles and scalpel cuts. So let me state the obvious. All scalpel cuts and injuries are important, but easy to ignore. What each one of us needs to remember is that every injury happens to a person just like you. This is unacceptable, yet for somehow we've managed to accept it. At the request of a number of operating theatre staff, Neville went on to develop a range of single-handed blade removers for the sterile environment. We've got blade cassette, blade needle system and blade single on the photographs. They were launched in 2007. They're quick, simple to use, but also they contain the blade, which means that you can do a count. And probably just as importantly, it means that the downstream staff are protected from injury even when the shaft's not disposed of completely correctly. Single-handed blade removers are specifically recommended by Queensland Health as part of their perioperative shafts safety procedures. Much to our surprise, we found that a lot of users have not been formally trained to use the blade cassette. For example, they were on night duty, they were on some sort of leave when the external trainer came in to show how to use the new product. To solve this problem, we obtained a federal government grant, employed a STEM graduate, collaborated with Monash University to develop this interactive instructional Clicksmart app. This blended training method means that OT nurses can learn how to use our blade cassette at a time convenient to them. Not surprisingly, Monash's team of experts were able to give us lots of tips to make the app more effective and more user-friendly. But from my point of view, I was very proud that when they tested the app, they could use it even though they'd never seen it before. With the COVID-19 era, we realised that staff safety would have to be supported in a different way, so we developed a digital platform where we have lots of free apps to help with education, training, how to run a trial, how to find the financial data you need for business case. And it can be accessed 24 hours a day. I'll flick through this very quickly. Michael Fletcher on the top left was one of 3 paramedics who invented the check-clip device to reduce medication errors. Glenn Riverston at the time was an ED nurse in Rocky, and after suffering a number of ampule cuts, he developed the snap ampule opener. One of the things that I've been very happy to see during the pandemic is the outpouring of love and respect for frontline healthcare workers like yourselves. On the other hand, I'm a bit scared that the heavy focus on PPE might backfire. Income is down due to elective surgery being down. PPE has gone up in cost per item and greatly in volume. As a result, budgets are more stressed than usual, and I'm concerned that staff safety will drop off the hospital's top priority list. The World Health Organisation World Patient Safety theme for 2021 is in fact health worker safety, a priority for patient safety. And their first 2 goals are preventing shafts injury and reducing work-related stress. So to finish very quickly, Clicksmart provides a unique, comprehensive shaft safety solution, which includes patented shaft safety devices, effective local and international advocacy, and the world-leading educational and implementation tools found on our digital platform. So we're able to support your shaft program, so get in touch with us to arrange a trial and to learn how to achieve full compliance in your OTs. And as a last request, our research and development has always involved clinicians, so we also invite you to share your feedback with us to ensure our digital platform can be fine-tuned and improved to ensure optimal efficiency and effectiveness when it comes to implementing the change required to have safety devices and procedures adopted. Thank you very much.